Welcome all. We're going to get started in just a few moments. Thanks so much for joining us today. Welcome all. For those of you in our audience, thanks so much for joining us. We're going to get started in just a few moments. Thanks for being here. Welcome all. We'll get started in just a moment. Thanks for joining us for today's webinar. Well, hi, everyone. Thank you for being with us today. I'm Michael Morella, Managing Editor of Events at US News and World Report. We're here today to explore the looming crisis of long COVID, and our panel of leading health and infectious disease experts will share the latest on the research, treatments, and potential techniques for managing this emerging challenge. As always, you can find more about today's guests and both past and upcoming webinars from US News Live at usnews.com/events. We are recording video of today's session and we'll be archiving that on usnews.com. And one final note before I introduce the panel, later on in the hour, if you have questions, we ask that you please type them into the Q&A feature in Zoom on your screen. We'll try to incorporate some of those as our time allows. Now I am very pleased to welcome our distinguished group of panelists. Dr. Philip Chan, Associate Professor at Brown University and Medical Director at the Rhode Island Department of Health. Dr. Priya Dugal, Professor and Vice Chair of Epidemiology at the Johns Hopkins Bloomberg School of Public Health. Dr. Kristen England, Founder and Director of Cleveland Clinic's Post-COVID Recover Clinic. And Dr. Bonnie Maldonado, Professor of Global Health and Infectious Diseases, as well as Senior Associate Dean for Faculty Development and Diversity at Stanford University. Thank you all and welcome. Now I'll turn the mic over to my colleague and our moderator, Liz Whitehead with US News Live. Liz?
Thanks very much, Michael. As hospitalizations and new cases of COVID continue to fall around the country, we now have the opportunity to focus on the long-term challenge that long COVID will pose to so many people. It is a confounding syndrome that will likely need the combined efforts of researchers and clinicians around the world to fully understand and treat. Kristen, I'd like to begin with you. As founder and director of Cleveland Clinic's Post-COVID Recover Clinic, can you start us off by describing what long COVID is and how variable are the symptoms the clinic is seeing?
Absolutely, Liz. Thanks for having me here today. But long COVID is also known as PASC, and you'll hear us refer to it as that as well. And that's the Post-Acute Sequelae of SARS-CoV-2. I also like to call it the pandemic after the pandemic, because as you're going to hear, this is going to be sweeping in its volume. But these are both terms that are used to identify a wide variety of either new, returning, or ongoing symptoms that last more than 28 days after the patient's initial acute diagnosis of COVID. Lots of studies have given us a wide variety of ideas of how many people are going to be involved, but the average number is about 30% of patients that have been diagnosed with PASC with COVID are going to go on to have long COVID symptoms, and it can involve nearly every organ system. Early studies talked about profound fatigue, shortness of breath with exertion, joint pain, chest pain, loss of smell or taste, diarrhea, and headache. You can see how wide that variety is. But soon afterwards, we then started hearing about symptoms of cognition issues, of brain fog, memory impairment, insomnia, anxiety, and dizziness. It would make sense if these symptoms were showing up just in people who'd been hospitalized on a ventilator. We can all picture the lung damage that would cause long-term shortness of breath, but 75% of our patients with long COVID were never even hospitalized, and less than 10% were sick enough to be in our intensive care unit. So we've got a lot to learn about this disease.
Phil, you're advising the long COVID initiative at Brown School of Public Health. A colleague of yours recently described long COVID as a challenge that may plague the US for generations. Can you give us a sense of the scope of this challenge, the number of people likely affected, the impact on daily lives and in the workplace, even the cost of care? How do we get our arms around how big a problem this is?
Yeah, thank you, Liz, and thank you for inviting me to be here. So I like the way that this is described, a pandemic after the pandemic. And I think we've been so focused, especially the last couple of months, on the acute phase of the pandemic that a lot of people across the US, across the world, haven't given a lot of attention to what comes after. But this is what comes after. And the estimates that I've seen are between 30 and 50% of people may be affected. And that's talking about typical long COVID. One of the things too is that it's really been difficult to wrap our arms around the true burden of long COVID. One, because again, I'm reminded this whole pandemic is still relatively new. We've only been going through this for 2 years, seems like forever. But we don't know how long people who develop symptoms after acute COVID infection, how long these symptoms will last. And I'm also reminded, of course, that there's other diseases too that aren't even encompassed in our current definitions of COVID. For example, we know that people that have COVID may be more likely to develop diabetes, to have heart disease, mental illness, et cetera. So just getting a handle on how we define long COVID and all the symptoms and the true scope of this problem, we have a long way to go. In terms of putting this in perspective, Liz, as you mentioned, I mean, here in the United States alone, we currently have over 78 million cases of COVID. So even if a much smaller fraction of that 30 or 50% develop symptoms of long COVID, that's still an astounding number. And at this current time, the best estimates do suggest that up to 1.3 million people may be suffering from long COVID and can't return to work. Some of the other studies that have been done have shown that it's about 75% of people with long COVID have had their work affected. I've had stories, in fact, I have a close colleague, history of mild asthma who developed long COVID, who had trouble breathing to the fact where she needed her inhalers multiple times a day for months. I have a physician colleague who described this brain fog, who wasn't able to return to work. So this is affecting people really across the workforce. And the latest numbers that I've also seen is that people are starting to claim disability because of this. The latest numbers I've seen on that as of December, and I'm sure that it's much higher, going to be much higher than this, is that the Social Security Administration has received 16,000 COVID-related disability claims, and I can only imagine that's going to be higher. So according to this preliminary data on what we're seeing, long COVID is certainly affecting workforce shortages in the US, and we are just beginning to understand the true scope of how long COVID is affecting us as a country and our workforce.
Bonnie, Stanford, of course, has its initiatives underway to understand long COVID and how to treat it and prevent it. But you have enormous global experience in infectious diseases. Can you analogize the research challenge that long COVID is posing and compare it to other infectious diseases we've tackled in the last 30 or 40 years, and how this measures up, and what have we learned that can be applied to this situation?
Yeah, thank you. Thank you for inviting me to be here today. So let me just start off by saying that we are one of 30 centers around the country that are part of the Recover initiative funded by the NIH. And this is a 4-year-long initiative to track three groups of people. One is prospective acute infected individuals, prospective people with PASC or long COVID, and then retrospective studies of PASC individuals. And the idea here is to enroll individuals, about 17,000 people around the country. Here at Stanford, we will enroll just under 1,000 over the next year, and then track them over time. But one of the things that you heard Dr. Chan talk about already, and Dr. England as well, is we have a lot of difficulties with this disease that we have seen before, for example, with HIV, Lyme disease, myalgic encephalomyelitis, these kinds of syndromic type of diseases where we really need to identify a case definition, for example, and know that I'm an epidemiologist, as epidemiologist, that case definition may hopefully evolves over time. So we need to have a broadly inclusive definition so that we can identify as many individuals as possible. There may be nuances that we otherwise might miss, and then you can tailor the definition over time. We certainly learned that with HIV. We really didn't understand that disease. If you remember back in the 80s, we started off with people who were dying of really unusual opportunistic infections, and we realized that that represented a very tiny tip of the iceberg with a 10 to 12 year evolution. So I don't know that long COVID will be the same kind of disease, but a lot of what we did early on was surveillance, tracking individuals, monitoring laboratory, clinical, and other parameters to see what the natural history of this disease was, and hopefully not just observe it, but try to treat it as well. So we have a long way to go, but we are starting off probably forewarned and forearmed, having had experiences with some of these other diseases.
Priya, can you pick up on Bonnie and the other panelists' comments? Can talk about what you're trying to do with the long COVID study at Bloomberg School of Public Health, and also perhaps some of the problems when you try to question patients who have, for example, comorbidities. What are symptoms caused by these other issues, and what is caused by long COVID? How do you tease out all this information? It just sounds like an enormous challenge.
Yeah, thank you, Liz. Thank you for having me as well. And so I echo what the other panelists have already said. It's a really complicated outcome. And I think we do have history sort of to show us that sometimes you have a specific outcome, a specific thing that happens after you've had an infection, and sometimes you have a myriad of symptoms that occur. And we sort of got the second here, where there is just almost every organ system affected, lots of different things from mental health to physical health that people are reporting. And so there isn't just sort of one definition that we can look at. And then it's even more complicated because it affects everyone in the population. And many people, starting in middle age especially, have a lot of comorbidities that they bring to the table. So we need to understand if those are exacerbating what we're seeing in long COVID, or if those are actually driving what we're seeing in long COVID, or if that's just what people are reporting because that's when it's happening at this particular point in their life. And so it makes our understanding of long COVID exceptionally difficult. And this has been going on already for 2 years, right? So trying to understand perhaps if variants affect it, if timing affects it on the individual, and then who chooses to report it.
So, Kristen, the medical community is in the position of needing to treat patients now who have a syndrome that it doesn't fully understand. What's the correct approach? How are patients assessed and treated at Cleveland Clinic right now?
Well, this is not unique to long COVID. As you've already heard in many aspects of medicine, we treat patients based upon their symptoms before we truly understand what is the underlying cause of them. And as an infectious disease doctor, I often see patients with fevers, and often high fevers. And if I wait to treat them until I know the exact cause, then these patients are going to get very, very ill. So I have to treat them for the fever, along with medications for the things that I assume may be causing that fever, and then try to dig at what's the exact cause of it. So we're kind of doing that here. So for our long COVID patients, I need to know the symptoms that they're having. That's the first and most important thing up front. So we give patients a lot of detailed questionnaires that they can fill out ahead of time, looking at what's already been kind of alluded to, but the anxiety, the depression, the PTSD that they may be having, some of their quality of life questions. And these are very standardized questions used in many different settings. We try to get an idea of their pre-COVID health. So again, what are some of their background illnesses that are either being exacerbated, or are we seeing brand spanking new episodes of diabetes? We look at the events during the COVID illness. Were some of the medications that they got during their disease process impacting their ability to go on and have long COVID? And then we look at a very detailed list of their current symptoms. Well, most of our patients presented with fatigue, and about 87% of patients, that's their number one complaint. And that can be caused by so many different things. So a year ago, when we opened up the clinic, we started looking at very broad tests to try and determine things. We were looking at echocardiograms, pulmonary function tests, and a certain battery of lab tests on every patient. Now we've started to pare that down, realizing that the majority of those were going to be normal. Unless patients had a specific complaint of tachycardia or chest pain, would we then go on to have the echo. So our patients are evaluated in a central area. We kind of call it the hub and spoke wheel. And a lot of clinics are doing that, where we then surround ourselves with a number of specialists who have raised their hand to say, I want to learn more about this disease and I want to help out. So I have specific cardiologists and neurologists that I send patients to when the patient has tachycardia and dizziness and they're being diagnosed with a disease entity called POTS. And they can really have a lot of difficulty with completing their daily tasks if every time they stand up they get dizzy. We have a lot of patients being worked on with physical therapy and occupational therapy to try and help just with their deconditioning. Our speech therapists actually can help people do their memory retraining. And we also have integrative medicine and a lot of other folks, but that are working on these shared medical appointments to try and help patients understand that they're not alone, that they can connect with others, they can have their disease process validated. I think that's a big part of it. These patients are tired of being told, oh, just get over it and get back to work. They want to be validated for what they have and talk with others and experts about diet and exercise programs that can help them hopefully try to get back to a more normal life.
Kristen, just a quick follow-up on that. Because, as you said, these patients may have so many conditions that need to be treated at once, it can be overwhelming. Does it argue that there needs to be more completely integrated clinics like you have? Because otherwise, the patient would quickly get overwhelmed trying to figure out how to schedule all these different specialists, go to different places.
Yeah, I think it's really tough to be able to have every single specialty that a patient needs there on site at any one time. We can talk about how we can work on this in the future as we try to get more information out to folks who aren't necessarily in San Francisco, aren't in Baltimore, or here in the Cleveland area in large centers. But, what about the folks who are in more rural areas? How do we get the expertise to them? So I think we have a lot of work ahead of us to try and get this, either get patients better evaluated as far as what their complete needs are, and then to be able to deliver that as a package to them.
So if I can step in and
sorry, yeah,
make
sure.
a comment. Yeah, I think again, coming back to the HIV model, we found very early on that infectious disease doctors or general practitioners were really starting off taking care of these patients. And as we actually were able to describe the constellation of findings, we wound up being able to develop holistic care for these patients so that they actually knew that there were neurologists, cardiologists, other specialists who would be able to partner. And I think these hubs of care are things that can be modeled. There can also be resource checklists, as you heard, from urban and rural settings, places where there are disparities in care. If we can make it simpler for our colleagues to be able to track general clinical and laboratory findings over time, and then maybe have referrals on a regular basis to bigger centers, if possible, that streamlined care has already been done in a very good way for HIV. And we've had 40 years of experience with that disease. Again, it has protein manifestations, and we know how to build those models. So this may be something that we'll have to do with long COVID, but as you're going to hear from my colleagues, we need to determine what are those checklists, who are those individuals, and they're going to have to be tailored likely to each individual patient.
Phil, can you pick up on both Kristen's and Bonnie's comments? You serve as medical director at Rhode Island's health department. Can you talk about how you see the long COVID treatment challenge being addressed in different localities in your state? And how do you try to, as Bonnie suggested, get the expertise out to GPs and family doctors, et cetera, at this point in the pandemic?
Yeah, it's a great question. I've always believed that good healthcare is really access to primary care. I mean, our primary care workforce is really the gateway for so many diseases in terms of the healthcare system. And we really need to shore up our primary care workforce in order to address many things, but especially long COVID. And I think it is a team approach. As we talk about long COVID, it is engaging, involving the primary care community, as well as subspecialists. And again, I'm an infectious disease specialist, but really, there's not enough ID doctors or cardiologists in the world to treat long COVID. And we've seen this from the HIV model. In my pre-pandemic life, I was an HIV specialist as well. And to really address HIV and long COVID and lots of other diseases, really need to engage the primary care community. I will say, though, that this is, as we talk about this, the statistics that I've seen suggest that up to 25% of Americans don't have access to primary care. And we've all seen and know some of these barriers to primary care in general, people not having insurance, no clinics in their neighborhood, something that we've seen in our state as we thought about testing and vaccination efforts for COVID, and just lack of culturally competent primary care. So I think as we talk about addressing long COVID, we need to look at the bigger discussion of how to just improve healthcare access to all folks. In terms of the public health department and our role of addressing long COVID, for our state at least, and I think what public health departments can do is certainly work to educate the clinical workforce and provide updates and CME lectures about long COVID so that primary care providers and physicians can provide cutting edge care. It's something we've done in our state. We have a bi-weekly, 1 hour CME lecture. We've talked a lot about long COVID previously. We also have a major academic center, Brown University, led by my ID colleagues, Dr. Garland, Dr. Johnson, who, similar to some of the other clinics here, provide that subspecialty care integrated with cardiologists and neurologists to provide that kind of umbrella care. And I think finally, I'll just end this question by saying one of the advantages, and Liz, to one of your points about how we reach the entire population, including rural populations, one of the things that has emerged during the pandemic is the increased use of telemedicine. And I love telemedicine. I think it really facilitates access to healthcare, especially in rural settings, especially where they may not be any subspecialists. So out of everything that's happened, I really think one of the positive things has been this increase of telemedicine. I hope if there's any policymakers listening that we can continue that. We're working to continue that in our state of Rhode Island, but it really has been a huge positive effect on care in general, and hopefully we can leverage that for long COVID as well.
Yeah. Sorry. Would you, sorry, I'm the transgressor. Can you pick up on any of these points right now? Because expertise, getting care to remote areas, et cetera.
Yeah, absolutely. So one of the things that's been really interesting, and we're running a long COVID study here at the Bloomberg School, and it's a virtual study. So our aim is 25,000 people. And really, we launched it with the idea of trying to understand what was happening because we weren't getting clear numbers. And as you heard from Dr. Chan, the numbers sort of vary, and it's very dependent on how the studies have been designed. But one flaw that we clearly have across all of these studies is our ability to reach people. And so we are hearing a lot from women, and we are hearing a lot from white women. And it's very unlikely, given the statistics that we've seen for COVID and for hospitalizations, that this is unique to white women, but that white women, usually of means, have a voice and a platform, and they have used it so wonderfully to draw our attention to long COVID. But now it's sort of our responsibility to see who else is having these issues, who else is having symptoms. And so as much as it's important to educate, it's critical to educate physicians about how to treat long COVID or how to identify it. It's just as important for us to get the word out to people that if you're having exhaustion, if you're having difficulty walking up a flight of stairs after this infection 3 months later, you could have residual lung issues that you didn't even know about, right? If you're having brain fog, this may not just be because, it's been a trying time, but you actually could have some neurologic issues. And I don't say that to scare people. I think that we're trying to get people care. We're trying to get people to be seen. And the only way we can do that is if they come forward and sort of tell us about what they're experiencing. And then if we have partners on the other side, physicians and healthcare workers who are willing to listen to it, hear it, and treat it. And this is really a problem. It's especially a problem in urban areas, and it's a big problem in rural areas. So utilizing things like telemedicine, but here in Baltimore with our long COVID clinics at Hopkins, it's also about outreach, getting out into the communities and talking about it and seeing people and asking them, it's not normal for your heart to be racing or to have tachycardia. That's not a normal thing that you should be experiencing if you're a healthy individual. So if you are, it's important to try to get care.
Can I pause and have you talk a little bit more about a problem that has run through healthcare? For example, women not being taken seriously when they talk about, cardiac problems. Do you find that this is a big issue, that patients either don't know what their symptoms are, they're not sure whether to take them seriously or if it's all in their head, as it were? And are doctors fully educated to take their patients serious when they talk about anxiety from long COVID? Can you talk about that a little bit?
It's a big concern, right? It's a big concern on multiple fronts. One is that, it's easy to dismiss when we're in the middle of a pandemic and all attention is on people dying and being hospitalized. It's easy to dismiss someone who says, I'm feeling really anxious, or I have new onset depression, and to sort of say that we believe this is just because you're living through a pandemic. And there is likely a proportion of people that are experiencing this because we're living through a pandemic.
Yeah.
And that's why well-designed studies need to have this control arm, right? That sort of looks at people who didn't have COVID and what are they experiencing? What's been happening in these 2 years? But similarly, you also have people who are speaking up because they're caregivers. A lot of, middle-aged women are caregivers. They have a lot of exertion that they have to take care of children, and they're working and they're doing things. And they can sometimes recognize that things aren't normal in their day-to-day life, right? That exertion isn't normal. And to not then be taken seriously is just a slap in the face, especially when we've seen clear evidence, physiologic evidence that there are changes from COVID, right? That people have changes in their brain, they have changes in their lung, they have changes to their heart, there's increased diabetes. Like, we see that that's occurring. There's no reason to also then disagree that there are other changes that are happening that people are experiencing. We don't understand it all, but we can only understand it if people speak up. I don't want this to go the way of just ignore it. It's okay. Everything will be all right. I think that we've already seen 2 years in that that's not going to fly, that this is real. And at least in our data, 3 to 5% of people are debilitated. They can't function in their daily life. So we have to give that credit. If you can't function, that means you can't work. That means you can't take care of people. That means you can't be a productive part of society the way you were pre-COVID.
I want to move to the next question, but I just want to give Kristen and Phil a chance to talk about this idea of being heard, because I think it came up when we were talking about patients saying, thank you for listening to me. And Kristen, I'm also curious whether you've had people come to the clinic who didn't have a good experience elsewhere, or just didn't know where to go and didn't know if anybody would take their symptoms seriously.
No, you're absolutely right, Liz. I think what probably the main thing that our patients are expressing when they're first seen at our clinic is just the relief that, as I mentioned before, validation, that there is somebody, the Cleveland Clinic and all these other wonderful hospital systems have taken the time to put together groups to study this disease, and that it is letting them know that we believe you, we hear you. I don't have all the answers for you, but we're going to work together to get you to feel better. And patients have often already gone to another provider, whether it be their primary care provider, and I'm big into primary care providers. Trust me, I'm married to one, but I certainly do appreciate that not every primary care provider out there is as educated about what long COVID is and the needs of long COVID. And that's part of our responsibility, is to get out there and make sure that we get information out that this is something that needs to be addressed. But patients are not only hearing it from the medical system, but also their family members who or coworkers who may be saying, oh, come on, why are you working part-time? You shouldn't, you're just complaining that you're tired. That's not anything real when it really is. So everybody needs education about this disease so that we can then embrace the patients who are suffering through it.
Phil, do you want to add?
Yeah, thank you. I'll just echo that is one of the most common things that I hear from patients, is about them feeling dismissed and feeling like they weren't heard. And I think I'm just reminded that in the current healthcare setting and the current climate with the pandemic is, a lot of healthcare workers are burned out. And I'm just reminded from this conversation that sometimes I need to take a step back as well and just remind myself how important it is that patients feel heard, even if we can't do anything. And sometimes what I hear in my colleagues' voices and other physicians is just the frustration that we can't do anything, right? So much of us in medicine, we're taught that we want to act, we want to cure people, we want to fix things, and sometimes we just can't. And I find that just listening to people and validating their concerns is half of it. And the other thing I'd like to do is offer hope. I think this is one of the examples with long COVID is where we don't know a whole lot about the full story yet. I think reminding people this is evolving, that there's hundreds of millions of dollars going into research and development to understand this, and offering patients that hope for the future, that we will have a better understanding of this, we'll be able to treat it and help them get better at the end of the day.
Bonnie, can you pick up on some of these points? The word burnout came up, and there's two parts of the equation. There's the patients, and then there's the people who have to cure them. And the pandemic has had an enormously detrimental effect on the clinician workers.
I am a baby boomer, so I can tell you from my perspective, the Great Resignation is real among the healthcare workforce. We currently have about 30% of our healthcare workforce that's already considering early retirement. This is a tremendous amount of institutional memory that is going to be lost. We also know that we are already in deficit, 124,000 healthcare providers, and that we're going to need to start recruiting not only physicians, but healthcare allies and other allied providers. We know, for example, that there are about 22 million people in the healthcare workforce now. About a little under half are physicians and nurses, and many of those people are at risk for in retirement age, and if not in retirement age, are seriously thinking about leaving. One other area that I want to talk about, because we have a platform here for hospitals and physicians and leaders, is that we are also not paying attention to our academic workforce. That is, in the past, it was estimated that about 4% of the academic of physicians in the US were physician scientists. We're seeing now about 1.5%. And that was before the pandemic. There are a lot of reasons for that, mostly financial. But if we want to make these amazing discoveries, obviously not all of them need to be done in an academic medical center, but in order to train these individuals, we need to really reinforce that we can bring these people in to our workforce. And in the end, it boils down to access. School debt is incredible. We're losing a lot of people because of school debt. Or bringing them in. And again, primary care is great, but we also need that very small percentage of individuals who can push forward and become the next physician scientists who can help us make these discoveries. So, and then the last area around disparities is, remember, this COVID pandemic really impacted our minority and underserved communities disproportionately. And they are frequently the people who don't come to the clinic. They don't know that there are clinics. They don't have anybody recognizing the symptoms that they have right now. And they also probably couldn't go to a clinic even if they knew that there were ones, because of the things you heard already. These are people who doubly have home responsibilities, work responsibilities. Some of them have 2 or 3 jobs. And so we took care of a lot of these patients early in the pandemic. And many of our patients here in California were Latinx or Asian community populations who were frontline workers. They have no access to regular care updates. So these are populations where we really have ramped up, and I know all of us here can say the same, ramped up our community engagement to make sure they don't come to us, we have to go to them, and make sure that our communities are healthy. This is the backbone of our economic workforce.
Well, yeah, I mean, if you don't have enough people to do the discoveries to cure the disease, and then you don't have enough doctors to apply the treatments, you can't help people. So Priya, Hopkins has a long history in Baltimore doing outreach to underserved communities. Can you add your thoughts to what Bonnie is saying? And also, Hopkins has tried to do a lot with addressing staff burnout, which is essential if we're going to have enough people to treat patients with long COVID. Do you want to add some thoughts?
Yeah, no, I can only echo what Bonnie said. I think it's spot on for what needs to be done. I think starting with finding patients, that's community outreach, and you can't just go out there, right? It has to be built over time, and it has to be built with community leaders. And so we're fortunate that there's a lot of research and service that's been done in our local communities already that we could use to our benefit, meaning that we could help them and they could help us to understand what was going on with disease. But ideally, when this pandemic hit, many of us wanted to just go out there and start working, and you just can't. Trust has to be built in communities, and so that's one thing that's important, is sort of having that relationship either through churches or community centers or other areas where you can reach them. And I'm hoping that the NIH initiative of Recover really it provides us that vision of inclusiveness that we really need when we're looking at long COVID. Because if we're only looking at one group, it's not going to help us in the long run, because all of these are patients that we're going to have to see. And then with regards to burnout, I think that's something we just have to think about in general. It's not just the workforce and what will happen, although that's huge, but it's just our day-to-day. If all of us are already struggling with burnout, imagine the person who also has long COVID that's dealing with burnout. It just exacerbates things. And I think that we really have to keep a really clear eye and come up with some solutions of how we can help people deal with what is going on when we were already in a fragile system, right? Even healthcare was in a fragile system in terms of nursing shortages and other people working. How do we sort of handle this in this moment? I don't think it's going to be easy.
We've talked a little bit about reaching different population groups. We haven't talked yet about what we're seeing in terms of what demographics are most affected by long COVID. Phil, do you want to start? Do we have any data that you're seeing on men versus women, 65 and up? I know we're very early to figure out the pediatric population, but do you have any thoughts on what we're seeing with the early data?
Yeah, great question. So as we've talked about, a lot of risk factors and just our understanding of the epidemiology of long COVID is still emerging. One thing that has come out is that women do seem to be more affected by long COVID, and it's really unclear why. There's a couple hypotheses about why this may be. One is that women in general may be more likely to be affected by autoimmune responses. So in general, autoimmune diseases are more common among women. And then one point that was brought up is that sometimes women may be more likely to seek out care. So there may be a behavioral or a gender reporting component to that. But we also know that aside from gender, the different groups of people, so folks that are older and folks that have more health conditions are more likely, of course, to develop severe COVID and more likely to have symptoms of long COVID, which I think makes sense. And I think to echo some of these other points that have been made is that we've learned through the pandemic that different racial and ethnic minority groups are significantly disproportionately impacted by long COVID in terms of number of cases, hospitalizations, severe disease, et cetera. And so just by the numbers that we expect a number of these groups, specifically Hispanic, Latinx, African-American, Black individuals, to be disproportionately impacted by long COVID. So as has been mentioned, we really need the support systems, we need the healthcare infrastructure, we need to address these social determinants of health to be able to accurately and adequately address health equity in these populations. And finally, the other last point I'll mention here is that I also serve as Chief Medical Officer of Open Door Health here in Rhode Island. We're the state's only LGBTQ+ community clinic. So as we talk about disparities too, we also need to look at different diverse sexual and gender groups and how long COVID may affect those groups as well.
Kristen, can you pick up on some of these comments of Phil? And also, there was a very interesting study that came out in January identifying some of the risk factors or suggesting there may be some risk factors that indicate which patients are more likely to get long COVID. Can you pick up on Phil and then maybe address the new study?
No, absolutely. I agree. I think we're seeing a predominance of women in our clinic. We've seen over 1,500 in the last year, 1,500 total patients. And we are seeing about 25% African-American or Black patients that have come in, but we have not had good outreach into the Latinx population. But we've seen ages from 18 to 89, with the average being about 49 years. But I've had calls from patients or parents looking to get children in as young as 3, which is just terribly sad. And we're only seeing adults, but I do think there needs to be more attention paid to the potential for long COVID in children as well. I wonder if some of the issues with our folks who are the age of 65 and older, they might be more likely to attribute the symptoms that they're having to simply old age. There was a study that looked at cognitive issues and memory lapses in post-COVID, and it really kind of tailed off after about 60, that patients were complaining about it. And I wonder if patients are having that, the symptoms, but an 80-year-old might be more likely to say, well, I'm just forgetting things because I'm 80 years old, as opposed to attributing it to long COVID. But more to find out. Yes, I think we're seeing a plethora of wonderful articles that are coming out regarding long COVID, and we're really starting to get not just down to the kind of the epidemiology of it, which we still have so much more to learn, but also to the cellular level. And the article that Liz is referring to here was published in Cell within the last month and a half. And it's a wonderful collaboration amongst several different research labs. So again, highlighting the fact that we shouldn't be standing on an island trying to do this ourselves. We really need to be working together on this. But they looked at blood samples from about 300 patients at the time that they had their COVID diagnosis, their initial acute infection, and then correlated that with those who had the long COVID symptoms 2 to 3 months later. And they really did a deep dive looking at the cellular level and looking at some of the autoantibodies, the cortisol levels, looking at some of the T cell responses, specifically the cytotoxic T cells. And they tried to correlate some of the findings that they were having with what I think some of us clinicians have been trying to do, which is to break long COVID down into a series of about 5 groupings. As we talked about, there's so many different symptoms up front, and while fatigue runs through almost all of them, there's some patients that tend to have more respiratory symptoms, and some that tend to have more neurologic symptoms, including insomnia, anxiety, and even POTS is included in that. But then there's some folks who have more GI symptoms, some more arthralgias and musculars, and then more of the cardiac symptoms with the tachycardia and dysrhythmias. So kind of 5 groupings. And this collaboration really just did some early groundwork trying to look to see if there are any factors that you can find in somebody when they're initially ill that predicts if they're going to go on and have any of these PASC symptoms. And I won't necessarily go into the details of that, but it does give us an opportunity to look at, if there's a higher level of the SARS-CoV-2 viremia when somebody's first ill, and they tend to go on to develop, let's say, more neurologic symptoms, well, then maybe we need to be treating them more aggressively with antivirals right off the bat. So giving us at least some hope that there's going to be a framework of initial studies that we can look at so that we can direct our treatments against that and hopefully prevent PASC. So that's the key thing with this. They looked at reactivation of Epstein-Barr virus and a few others, but one of the things that they came down to is that certainly patients with type 2 diabetes seem to be more at risk for getting long COVID and long COVID, and I think we'll look at that. And then a study from our endocrinology group at Cleveland Clinic seemed to give an indication that moderate to severe obesity is also a risk factor for developing long COVID. And I think we're seeing this play out. The average BMI at our clinic, our long COVID clinic, is averaging over 31. So that, certainly obesity, as we know with acute COVID, is a risk when it comes to this virus.
Thank you, Bonnie.
So, yeah. Let me just step in. We have done some preliminary work. Our labs were part of that paper, the Cell paper, but we've done a lot of discovery work. Really, again, just as you said, very early. And some of our physician scientists here, MD, PhD in particular, have looked at things like infecting of. So one of our colleagues found that the virus tends to have an affinity for infecting fat cells. And these fat cells then develop a massive inflammatory response themselves, which I think had not been really characterized before. So that's one theory, again, as to how this may be important. Another one of my colleagues looked at antibody production, and autoantibody production. He's a rheumatologist, PJ Utz, and really identified this as a predictor of potential for progression of disease. And then the third person did some work looking at the types of antibodies. And it turns out that a fucosylated antibodies, that is a particular type of sugar, predicted less severe disease, and conversely, non-fucosylated IgG, so lack of this sugar moiety early on, predicted severity of disease. So a lot of the studies right now are trying to say, can we identify particular, as you indicated, Kristen, are there blood tests or other markers that we can look at to then think about, are these people, first of all, what's the functionality? Why is this happening? And it looks like inflammation may be one key, but the other, at least most of the data show that inflammation is a big issue. Now, whether or not that's true for Omicron is going to be interesting, because we don't see that Omicron elicits the same kind of inflammatory response, but it will be important to see if that's true for variants down the line. But it could also lead us to a potential for screening. I mean, all of us take care of patients who've developed the flu, and the big question always is, well, do I really need to use oseltamivir? And, obviously, as ID people, we say yes, but a lot of people say, well, if you gave oseltamivir to everybody, how do you know it's really going to make a difference? So this would be a way to identify people at high risk for progression and see if starting early antiviral therapy, as you indicated, Kristen, might really reduce the risk along with vaccination and boosting. If you then treated these individuals, would that be ultimately what we want to see, is a reduction not only in hospitalizations and deaths, but perhaps in long COVID?
Priya, do you want to pick up on this? And Bonnie mentioned some differences in the different variants and their impact on patients. Is that something you're trying to tease out in the Hopkins studies also?
We are. So, time is sort of beneficial to us because we're capturing when people had their infection. And then, of course, then when they have long COVID or the long-term symptoms. And the way that the variants have really worked is, although there's been some overlap, for the most part, as Omicron came in, Delta just sort of disappeared. And we can see that sort of that emerge across the United States at different stages. And so we're able to take that information in and see what likely was circulating at that time for an individual who had long COVID. Was it Omicron? Was it Delta? Was it Alpha? What did they actually have? And that's really because we don't have that on everyone, right? We don't have everyone's actual virus variant that they had, because most people weren't being sequenced and then have that information. I think it's going to be really telling because Omicron is very different than Delta. The outcomes have been different. Where you get infected is different in terms of upper respiratory versus lower respiratory. And the amount of time that you're shedding, though, seems to be somewhat similar. And that may play a role here. We talked about obesity with flu. We see people who are obese tend to shed flu for a long time. And so is this inflammatory and reflective of shedding as well with COVID, or is this just inflammatory reflective of what you see within your body and how you respond to it in terms of the autoantibodies? So I think several different ways that we're going to have to sort of dissect this, and hopefully in the coming months and years, we'll get a better picture.
And just one quick follow-up. The question everybody is asking is, if you're vaccinated and boosted, does it reduce your likelihood of getting long COVID? Do we have data on that?
Yeah, so I just want to say I'm very pro-vaccine here. So what we do know is that if you get vaccinated, you are less likely to have COVID. And so that's the most important thing to start with, whether or not you're going to have long COVID. And that's just because of what's circulating, the people that you're around, the community levels. But there has been data that's come out of Israel and other places that have suggested very strongly that people who have had both doses of their vaccine are less likely to report long COVID symptoms. And we actually see that in very cursory results from our own data, that the people who've had both vaccines are less likely to be the ones reporting long COVID symptoms. So it's not yet causal. We can't say, okay, for sure, because you got vaccinated, you won't have long COVID. There are people who have breakthrough infections and end up with long COVID, but it does reduce or mitigate the chances that you will have long COVID.
Phil, do you want to pick up on some of these comments? And then I want to ask you to deal with the messaging question on the importance of continuing to prevent your getting disease, long COVID, prevent yourself getting COVID in the first place. And are we pushing that message hard enough against all of the misinformation. But first, do you want to just talk about what you're seeing at Brown on the impact of vaccinations and boosting on long COVID rates?
Yeah, and I'll just emphasize what Dr. Dougal mentioned, which is that too early to tell, but certainly, as was just mentioned, vaccinations reduce your likelihood not only that you're developing infection, but also severe infection. We know that people who tend to have more severe COVID are more likely to develop long COVID. So in my mind, it's going to be clear that vaccinations certainly likely reduce long COVID in general. And we've seen that with vaccinations and reducing the likelihood of MIS-C, multi-inflammatory syndrome, in children as well. And the only other comment I'll mention just related to this is that, especially with Omicron, there's BA1 and BA2, and there's even differences within the variants potentially about some of their pathophysiology and how they, what receptors they bind to. And it looks like BA2 may cause even more severe disease than BA1. So there may even be some intravariant impact on long COVID, but this is also evolving. I mean, I'm just remembering that, we just got over Omicron. It was first discovered in November. So it hasn't even been a couple months here since we've seen the majority of cases.
Can we talk about messaging, Phil, a little bit about how it is an enormous task for the public health community to beat Facebook, to beat all the misinformation that's going on the internet about vaccines. How are you trying to combat that in Rhode Island, and how successful are you? And what is the role of family doctors versus the state, localities, and the federal government in terms of getting the messaging out to all communities?
Yeah, I think one of the more disappointing aspects of what's happened the last few years, even before the pandemic, is just the misinformation and the myths related certainly to COVID and what we're talking about today, but just in general. I really do believe as a society, as a democracy, we really need to focus on facts and evidence and science to guide our decisions. And many public health departments, and I'll speak on behalf of the Rhode Island Department of Health, have worked to just combat myths and misinformation. At the moment, I'm proud to say that Rhode Island actually has one of the highest vaccination rates in the country. And it's really been a ground game. I think, as was mentioned, you really have to go out and meet people where they're at. We've really focused on health equity. We've gone into our geographical hotspots of infection and disparities, often related, of course. We've set up vaccination sites, testing sites. We've worked to build up infrastructure. We made sure that our messaging campaigns are in multiple languages. We've given numerous, too many to count, forums in different languages, communications campaigns. It's just a matter of meeting people where they're at, partnering with the local community, stakeholders, churches, trusted professionals in the communities where people live and work. And it's been successful in our state, but of course, there's always so much better we could do. And we're going to have to do something very similar as we talk about long COVID in general.
I'd like to pause for a second. We had a question from a patient in the audience that just captures just how stressful and difficult it is to be somebody who has long COVID. I have been researching long COVID since I contracted the virus back in March of 2020, and I still experience blurred vision, memory loss, and hearing loss, to name a few additional symptoms. Was my brain affected by the virus? Will I be susceptible to any common viruses in the future because of how COVID has affected me? And that is so difficult. We have other questions of people outside of academic medical centers. Where do I go first? Where do I go for help? If I'm, in a town that's 60 miles outside of a major metropolitan area, what should they do? What advice can we give to long COVID patients?
So let me just start off by saying that it's really unfortunate, and I'm so sorry to hear about these symptoms. I think all of us here have been dealing with these questions. I'm a pediatrician, so we have actually been seeing children who have very similar concerns, and many who can't even articulate their symptoms because they're too young. We are working really hard across the country, as you heard, to build these programs. There are many different kinds of programs. We're so early. It seems like 2 years is a long time And it certainly is a long time when you are suffering from these. But the best thing I would recommend, and I'm look forward to hearing from my colleagues, is to find a provider, public or private, wherever you can find a provider, and just let them know that you are having symptoms. And if they can help you, at least to try to understand some basic ways to approach the problems that you're having now. If they can't help you, ask them to refer you to another provider who might be able to help. I do think what we've heard before already is that that a lot of providers are first of all, are overwhelmed just with dealing with pandemic-related stress and burnout, but may not really be aware of what types of therapies or interventions might be available, but encourage them to help you find somebody who can work with you. Nobody has the answers right now. Obviously, we are still looking, but there are some measures that can help at least mitigate some of the symptoms that individuals are having. And in the meantime, all of the big projects that are moving forward are enrolling individuals. So some people are being enrolled in these studies. And if you have access to, say, the Recover website, and I don't know, Liz, if you can post that for people later, but the NIH initiative websites, there's 30 centers around the US, there's 8 centers for children. They are actively enrolling thousands of people. I know others here have access to others. They may not be able to give you answers, but in my experience, having taken care of patients here, adults and children, just having a provider who can help you walk through it is at least one form of reassurance. And one final thing I'll say is there are also people out there who are taking advantage of people. We've already heard about at least 3 or 4 different programs around the country that are offering COVID therapy kits and giving combinations of drugs that are really not authorized for use in this manner. And just be very careful about going to the internet and finding people who are offering treatments. And I know it's difficult to know where the truth is, right? So this is where going to a public or private respected provider would be helpful, because we've actually had to refer some of these individuals back into regular care to deal with some of their symptoms. So be very careful about people who are offering the ultimate cures, because at this point, unfortunately, we don't really have one. We have ways to deal with some of the symptoms, but we don't have a cure at this point.
usnews.com will be doing a recap article on the webinar and posting it. We'll make sure we'll get that link up in that article. Thank you, Bonnie, for mentioning it. Do all of you want to mention, build on Bonnie's comments about where to get care if you're outside of the?
Absolutely. I mean, I think certainly, as Phil has brought up before, starting with your primary care doctor, and if you don't have one, engage one, get involved with the primary care doctor. And this is where you've got to be a team, and you've got to work with that person to try and, do some research and look to find respected, reliable sources of information and care. I couldn't agree with you more, Bonnie, that I think there are unfortunately bad actors out there right now that are trying to take advantage of this void of knowledge. And are offering an instant pill. And as we saw early on in the HIV, disease, some of them are frankly dangerous. I mean, people were talking early on in HIV about giving hydrogen peroxide infusions, and what is that? And yet people were desperate and were willing to try it. So if it sounds off, talk to your primary care doctor, because there's a good chance that it is. There is no cure right now. We just need to work through some of the symptoms and wait until we get better information and better treatments.
The only thing that I'll add to this is that we need to be careful not to dump things into long COVID, meaning a lot of people have been affected with COVID. I'm always conscious that I don't want to necessarily label people as having long COVID without ruling out other things that we can fix. So I'm just very conscious when people present to me with symptoms that I'm trying to think about what else it could be. Even if they come to me with long COVID, I want to be very conscious, of course, about what other things may be common, what other things may be presenting. And at least in this case, with someone with eye complaints, really the recommended approach would be to refer someone to an eye doctor and ophthalmologist for an in-depth eye exam to figure out what's going on.
Priya?
Yeah, I was just going to emphasize that that's one of the reasons we're asking people to go to their primary care provider first, is because they can manage it. It's what they do. They can help you get specialists that can see you. And although there is likely going to be very unique things about long COVID, right now we're treating symptoms. So being able to see specialists that you can see is ideal. That being said, if you are with a primary care provider and they are not hearing you and they're not listening to you, we're all here to reinforce that this is real and that there are other people out there that will listen to you. And for many, the clinics have been set up at academic centers, often by referral from primary care, but sometimes without. And that's just because academic centers had the ability to set them up. I don't think that'll be where they are long-term, but right now they're there. And you can always reach out to those physicians, like Kristen.
Thank you. Bonnie, to close, can you give us perhaps some thoughts of hope here? Do you feel that we are getting better in the development of therapeutics? And do you think that there is a good chance we'll get to the root cause of the inflammatory response of long COVID in the near future?
Well, again, there's a dual message here. I think a lot of us here, just by nature of the work we do, are optimistic. We are really proponents of discovery and tracking data and really helping to understand. Now, that does take time, and for people who are actively afflicted, feeling symptoms, I'm sure it's anxiety provoking, and it certainly is for us as well. But we do know that there is a very large development pipeline. There are hundreds and hundreds of therapies that are being evaluated right now around the world. I work with the NIH on their active 3 trial. So we're evaluating treatments now for immediate disease, and it's possible that treatments for disease may actually mitigate long COVID. We don't know that yet. So, or vaccines, as you brought up earlier. So I think it's, we are evolving much faster than we have, for example, for myalgic encephalomyelitis, for HIV. That took, 20 years before we got really anywhere close to getting, it to become a manageable chronic illness. So I think we're in a much more rapid state of discovery and treatment than we were for other diseases. But that said, please take care of yourselves, because the day-to-day, I know, is very difficult, getting up in the morning and just making it day through day. So be kind to yourself. Make sure, as you heard, go to your regular providers, and they will help you keep up with the latest, and really consider wellness approaches as well, to be able to deal with the day-to-day burdens of carrying this long COVID. And we do see that many people are resolving over time. So we're very hopeful, and we know this is a critical time in developing our knowledge of this disease.
Thank you. Doctors Bonnie Maldonado, Kristen England, Priya Dugal, and Phil Chan, thank you so much for bringing your expertise to this extraordinarily important topic. I think we all share the hope that your collective efforts, along with your colleagues worldwide, will result in effective treatments for sufferers of long COVID, and eventually to a greater understanding of how to prevent it. Thank you so much.
Thank you, Liz. This was wonderful.